forward. Thank you. I'll go ahead and do our introduction. So welcome to the Center for Suicide Prevention and Recovery Spotlight Series. So this is our monthly presentation of research either within our own center or from other centers that's new and interesting and innovative. And we really have been interested in things that kind of address the kind of get us out of the box and try to come up with some new ways to think about suicide prevention and sort of the care we provide to people who are suicidal when they meet us in the healthcare system. So today, it's my great pleasure to introduce Ashley Hagaman, Associate Professor of Public Health in the Department of Social and Behavioral Sciences at Yale School of Public Health. I got to know Ashley through the Society for Implementation Research Collaboration, or SIRC, where we were matched for mentorship. And I just say I'm always impressed with not only the quality of her research, but the depth of collaboration with her international partners and her really cool, innovative ideas that have come out of that work. So I'm really happy that you could come, Ashley, and share this with all of us. Ashley leads a suite of hybrid clinical trials and developmental studies focused on global suicide prevention, implementation science, and maternal health in low and middle income settings, with a particular emphasis on approaches centering health equity and lived experience. Her teams develop implementation strategies to scale packages of brief intervention for suicide, tailored for their resource-constrained non-Western context, with established field sites in both Nepal and Pakistan. Ashley's scholarship seeks to dismantle neocolonial global health approaches, and her research teams on the ground are led exclusively by female scholars with lived experience from diverse caste and ethnic backgrounds in Nepal and Pakistan. Ashley is a qualitative methodologist and anthropologist and provides leadership on innovative ethnographic models to improve implementation measurement and design. She loves coffee to fuel her work and playing and hiking with her kiddos and partner whenever she can. Ashley, I'll hand it over to you.
I just laughed at myself because I wrote that. But it's true. Hi everyone. I'm so happy to be here. Thank you so much for inviting me to share some of the work that our teams do. And let me share my screen. I'm sort of a Luddite, so sorry if anything okay, you guys are seeing the right thing, yeah?
Yes, perfect.
All right. So am I seeing the right thing? Okay, all right. It's not lost on me that this talk is really talking about decolonizing, and I'm the one giving the talk. And so right now is like literally the middle of the night in Pakistan and Nepal, and that seems to be how it often is. And so, really who should be here is my colleague Siham Sikandar, Sidra Mumtaz, Gul Saeed, Kripa Sigdal. And so I wish that they were here. And so, but you get to hear it from me, and happy, our team is always happy to chat more and also learn from all of you. So I'm going to talk to you about a suite of projects that we've been working on that sort of anchor more or less around kind of what the West has called crisis planning or safety planning as this kind of like key strategy that we've been using to make up for the gap, and just like sort of create more intentional care pathways that make sense to folks that are managing suicidal thoughts and behaviors. And so, first I'll say a little bit about the global burden of suicide, although I will say over at University of Washington, there's an incredible global health department. I know there are classes on global mental health. I think I've given a couple of guest lectures in them. And so I'm mindful that many of you probably know a lot of this already and are perhaps like working in it. More than 700,000 people die each day by suicide, and up to 16 million people might attempt. And up to 3/4 of all of those deaths and attempts happen in low and middle income countries. 1 in 10 individuals, and this has been, I feel like I say the same statistic every time. Um, that of the 10 individuals that might need mental health care, only one might get it, and the quality of mental health care that they do get is unknown, and likely um, uh, uh, not high quality. And that's magnitudes larger. That disparity of 1 in 10 is magnitudes larger of the, certainly also really big disparities that we see with marginalized and oppressed populations and minority populations accessing mental health care here in the United States, right? And so these things are just really amplified in low and middle income settings. And then some of the stuff that our team, thinks a lot about is how, knowledge and interventions are anchored really heavily on Western theories of suicide. And so in the past few decades, there's been sort of this proliferation of some newer theories related to suicide that help guide risk determination and then also intervention. But those still remain sort of derived and anchored in the West. And so uh, you can also see that in the data and just who is studying suicide and where suicide is being studied. And so this is, it's our librarian here at Yale just ran the search for me to see kind of what proportion of suicide-related studies were done in a low and middle income country, and it was around 11%. And so there's just really incredible disparity in both burden and in science. And so that's a lot of the work that the teams that I have the privilege of working with think a lot about, is that they're trying to change that. In addition, hold on, I'm seeing something different on my screen, but not your screen. Okay. And the last thing I'll share that motivates some of what I'll be talking with you about today, and then some of the curious things. So a lot of these trials are happening right now, which is why what I'm about to share with you is, is like a little bit informal, because we're literally developing these things in the field as we speak. There were co-design workshops 3 days ago. But a part of, what we think a lot about, because we work in South Asia, is there are far more female suicide deaths in that region of the globe than anywhere else. And so what you can see is that orange bar is the amount of female deaths, and you can see that that bar is the highest in South Asia. And so it's a really important outlier, and a lot of the work that we do is really attending to that and then trying to understand why that is the way it is, and then how we can address it. I work with some just truly badass and just amazing, incredible scholars and human beings and clinicians. And so these are some of them. And none of the work that we do could be done without them. And I just feel so grateful to be a part of their team. So I wanted to show you some of them. And a part of what makes our work happen that I'm about to show with you, and I'm sure, again, is probably anchoring a lot of the work that you guys do in your communities, is that all of our implementation research is anchored in lived experience advisory boards, where we have co-investigators on our NIH grants, where we have formal sort of paid advisory boards of individuals with lived experience themselves and of clinicians, right, with lived experience working on the ground. And they are all a part of designing, deconstructing, and reconstructing sort of the work, the scholarship, and the interventions that we do. And so these are pictures of some of those advisory boards that really sort of guide all of our processes and procedures, from grant application and research design all the way through, sort of the instruments we're using and what we're measuring, and then of course what we're doing from an intervention perspective. To give you a sense of kind of how we think about some of this in sort of global context, and sort of culture and place, is that we, doing research on suicide in these contexts is really complex historically, politically, and then frankly interpersonally, right? And so really no clinical trials have ever been done on that are focused solely on suicide prevention in Nepal or Pakistan that are outside of like the immediate clinical context. In Pakistan, there's been like one that was really sort of clinical focused, but in Nepal, nothing. And so we're really thinking a lot about how do we begin to address some of the disparities that I told you about in a way that is thoughtful and slow to some extent, but then also sort of like working with in concert with systems and partnerships that can also make it relevant and speed it up and make it implementable today. And so we, see our work is really anchored in culture and context and like how to implement, right? So we're always thinking really pragmatically about what we're doing and why we're doing it, and then like what is the context in which we would be doing it. So like the individual is really important, but so is their community and the systems and the policies and the structures that they exist within. So like for example, in Pakistan, suicide attempt was decriminalized like 2 years ago. 2024, like December of 2024, I think. And before that, if you attempted suicide, it was punishable by imprisonment or fine. And we can't build a suicide intervention or ask people about their suicidality without considering the legacy of those policies. And so, there's lots of other examples here about things that we really try to consider. And so a part of our strengths as anthropologists and as an interdisciplinary team with the folks that I work with is that every part of the work that we do is considering a lot of these elements in order to optimize, the efficacy and likelihood of success of what we're designing. So what I'm going to talk to you about for the next, I don't know, like hopefully not more than 30 minutes, is kind of how we've really thought about decolonizing some of this crisis planning or safety planning through 4 co-design studies that we've either done or are conducting. So 2 are done. And then 2 are like literally in progress right now, sort of building on what we learned from the other 2. So I was just going to kind of walk you through what we're doing and what we're thinking about and some of the ideas that we have, and then also like what hasn't worked well and kind of where we're thinking about improving. And, I would love kind of your perspectives and feedback as well. And so these are probably very familiar to all of you. But it's funny, I just laugh because when I show this to, the folks that I work with, they're kind of just like, why the hell would that ever be helpful? But these are sort of what safety plans look like in America. And so on the left is the Stanley and Brown approach, which is this sort of written, like homeworky, sort of literacy dependent, tangible object that folks use that sort of makes a list of things. And then, of course, there's the Craig Bryan approach, and I'm sure there's other approaches as well. That's sort of this free-form approach to safety planning, but is still sort of something that is written. It is an object. It is a card that is put in a helmet, for example. And so both of these are thoughtful in that they, sort of like work with the systems, but then also the individual target populations. But if you sort of think about taking something like this to a place like rural Nepal, it just like makes very little sense. And so it's not the place that we started, right? So the place that we started in our work was really thinking about, what makes folks suicidal in the first place. And so I'll show you an example of that a little later. It's not up front, but we're always starting with sort of developing grounded theories and sort of understanding local explanatory models and ethnopsychologies around this stuff in order to develop targets for our interventions that make sense, and then also develop measures that make sense. But we're also thinking about, if we need to keep someone safe and give them somewhere to go in the context and systems that we're working, what would that look like, right? What would that do? And what can we do? So I'm going to walk you through. I guess I really like the hybrid type 2 design. That's like what all these trials are, except the hospital-based one. But a part of the reason that they're hybrid type 2 is because we're working in contexts where there really isn't a whole lot of effectiveness studies or efficacy studies on kind of like the clinical impacts of doing suicide prevention interventions. And so we just design them so that we're looking both at like clinical impact, and we're looking at implementation feasibility. And so these are all pilot studies, and I'm going to walk you through them because this is kind of like the order. Well, it's not the order. This is sort of the first three are in Nepal and the last one's in Pakistan. But I just show you this because we're really working at doing this crisis planning work or this suicide prevention safety planning work at multiple levels, in multiple contexts, in multiple spaces. So we're working in a hospital, we're working in the primary care system, and there's a reason that we moved from the hospital to the primary care system. And then we're also working in the community, right? And so we're working with the community to do like family integrated, adolescent focused suicide prevention. And then I also work with moms in Pakistan. And so I'll tell you kind of like how in all of these different spaces, this kind of sort of this like same idea of how do you keep someone safe and get them into care when they really need it, how it ends up looking really different when we do this co-design work. And so just to say, we started in a hospital, and we call it like the suicide prevention package. Uh, uh, the reason we started there was because in 2019, COVID, or 2020, COVID happened, and my colleagues at a hospital in Nepal, my emergency department colleagues, were like, every person coming in here either has COVID or has a suicide attempt. And um, they were overwhelmed with suicides like at that time. And so that's why they originally were like, Ashley, can we do something? And so all of this started because the emergency department doctors and nurses really wanted something to be able to do for the folks that were coming to them with suicide attempts, because they had never been trained in anything related to suicide prevention. But then they also wanted their system to be equipped with something for it to be helpful. And so that's kind of where a part of it started. And then we thought a lot more about kind of where does it make sense to start delivering these interventions, and it made sense to decentralize them out of the hospital. And so that's why you sort of see it centralized and then decentralized in different spaces. So the way we think about sort of packaging these brief interventions is sort of crisis planning is one part of them. And so whenever I'm talking about safety planning, it's being done in the context of a lot of other stuff. And so I'm not going to tell you about that other stuff much, except that that other stuff exists. And so a part of it is, a part of what we've sort of decolonized, deconstructed, reconstructed is like, how do you screen and ask about suicide in the first place if it is not well, actually, like even suicide attempts that come in are not often obvious suicide attempts because there's like a lot of layers of stigma and protection that happen. But in any case, in a place where suicide was only recently decriminalized, right? What is a way that makes sense to even ask about it in the first place? Or how do you even determine risk, right? And we've done a lot of thinking and a lot of work. Like we could have a whole nother conversation about how do you identify risk and risk severity in a place like Nepal or Pakistan, because it just seems to be presenting quite differently than kind of these like typical screening strategies that we have, like using the Columbia or using the ASQ or using some of these other ways. And so we've thought a lot about it and we failed a few times. And so now probably on like the fifth try, we're getting somewhere closer to where we need to be in that space. But how do you just get someone in a context where they can talk about this in the first place in a safe way, in a way that is trusting and that they think that you can help? Because there hasn't been legacies of like evidenced helpfulness in the health system before related to mental health and suicide. And then, when we think about safety planning, we think about it in like a sort of much more contextual way. I'll tell you about that in a second. But then we always are pairing that safety plan with something else, like contact follow-up or this sort of like peer connection. And so when I'm talking about safety planning, it's always being done in the context of all these other things. And the other thing I'll talk about, because it's relevant in all of these other studies, is, when we're thinking about suicide in these contexts, you need something, right, in order to sort of ethically start doing research within it, and intervening upon it, needs something there for the folks that are suffering from some of these conditions or sort of trying to manage these thoughts and behaviors. And so what is there is something called the MH-GAP. That's the Mental Health Gap Action Program. I'll tell you a little bit more because it becomes really central to one of the projects I'll tell you about. But the MH-GAP is a WHO evidence-based training program that capacitates primary care clinicians to detect and treat common mental disorders. And there's like 8 common mental disorders and suicide prevention. And so the Mental Health Gap Action Program is rolled out nationally in both Nepal and Pakistan. That means the primary care workforce is trained to detect depression, anxiety, schizophrenia, psychosis, epilepsy, some sort of common child behavioral disorders, and manage those both with psychosocial management and pharmaceutical management. So in both Nepal and Pakistan, I'm just trying to sort of share that when we think about this work, we're often working with systems that are capacitated to address mental health in a pretty systematic way. Although not with barriers. So, okay, so I just was gonna, so the first thing I'm gonna show you is like the first time we tried this, and then you'll kind of see how it iterates through the other clinical trials. And so the first time we tried it was in this hospital, an open pilot trial that was funded by the American Foundation for Suicide Prevention, which I am so grateful that even though they're the American Foundation, they, thought that funding this work in Nepal was important. And so we did this through an open pilot just to make it feasible because the focus was really on like deconstructing and reconstructing these brief interventions for suicide. And so this was like generally our process. So I'm just trying to give you a sense of like kind of how we did this. So over the course of a year, I would say, we recruited and hired a community advisory board and an advisory board of implementing health system clinicians. And they sort of operated collaboratively, but in distinct ways. And so before we even started, like even getting an advisory board of people with lived experience was like a very sort of slow and thoughtful process that we had, because this was, again, it's not like there are sort of AFSP support groups that are sort of around, or like advocacy groups that are thinking about this stuff. Like it really is something that like people don't connect around. And so we start, I'm an anthropologist. And so we start with a lot of life history and lived experience interviews of people that have attempted suicide, and as well as family members, and then of course health system stakeholders. And so that formative part that you see was the grounded theory development part of it, is just understanding how are people experiencing, how are people thinking about and making sense of these experiences in these really complex sort of like stigma laden ways. And then also, what help are they getting and what help is helpful, or like what has happened. And so we did a ton of that through a lot of those, like, I don't know, it was probably like 40 or 50 interviews that we did with people that had attempted and their family members. We recruited a community advisory board, and that board has stayed with us for the rest of the duration of the project, the next couple of years. And they worked through regular meetings, I think monthly for the first year. before, and then like quarterly after that, on sort of developing this like cluster of brief interventions. And so how do you ask about suicide? How do you manage immediate risk? And then what are we going to do about it in the long term, which was the contact follow-up part. And so in that sort of co-design process, in those meetings, we really start with a lot of trust building and storytelling and illustrating. And so at every meeting, we often have an Indigenous artist that's there to create visuals of what is being talked about. So it's not like we never have a PowerPoint. We try and make sure that we can visualize kind of what's being discussed, that we can visualize the types of decisions that the group is making. And I think that sort of first part about trust building is really ensuring, particularly in this context, that we're able to address like power dynamics in a way where the community is comfortable critiquing and just really comfortable telling, challenging ideas, each other's ideas and the research team's ideas, but then also sort of like making sense of things together. And so just, there's like a lot of time that's spent on doing that, especially because culturally this idea of like critiquing is really difficult. And so it's something we think a lot about, something that we develop a lot of strategies around. Eventually, we would get to this idea of like generating ideas where in sort of like typical human-centered design, like you're sort of like listening with empathy and understanding, and then I'd like sort of generating some of these ideas. All the ideas that we generate, again, are sort of documented by these artists, and the artists start creating visuals for things or prototypes for things that then get shared back to the community advisory board. Once we have a prototype, we start talking about like how are we going to implement this thing, and that's where we talk about co-creating the implementation strategies in order to like, okay, now that we have this idea of something to do, how are we going to do it, and what are the anticipated challenges? And then we develop an implementation strategy menu that we could test out. Once we have those things together, we go and pilot it out in like honestly the real world, where we like bring it into the emergency department, for example, in this study, and we test it out and we see how it goes, and then we see where it fails, and we bring it back to the cab to further improve. I hope that process makes sense. And so what sort of this particular project developed, which sort of has been agreed upon with subsequent projects, which we're excited about, is sort of thinking about this brief intervention called Asha Kodio. Asha Kodio in Nepali means like lighting hope. It's sort of like an activity or an action that's done both spiritually, but then also just like generally. And so what they ended up recommending was this idea of like crisis, not sort of calling something a safety plan or a crisis plan, but creating this Asha Kodio. And so we don't use that language of safety planning or crisis planning. We just say, here's your Asha Kodio, or let's do this Asha Kodio. And then the other thing is we made, as much as we could in this project, we made everything visual. And so in order for someone to have like a plan of what to do, or sort of like kind of what to do with their suicidal thoughts and behaviors, right, once they've been disclosed, is visualizing each of these domains of what they could do. So what the CAB did was they created these stickers of sort of all of these menus of options that people could have for things that were documenting their, own coping strategies, their distraction techniques, their preferred help-seeking pathways, whether it was a traditional healer or their peer or, someone in the health system, for example. And the other thing that we also developed as an implementation strategy was this pocket card. And so the stickers are what you see on the left. Of some of those things that as sort of they get facilitated through their Asha Kodio, they pick them and they can put them on their plan. And then this thing in the middle is the pocket card, which was like sort of this like reference for both the person implementing the plan. In this case, it was a nurse. in the emergency department or in the psychiatry department, who sort of got like a special certification, and she was called a suicide prevention specialist, and then she sort of carried that with her in her career through this hospital system. But in any case, this middle thing, it's sort of the domains of that Asha Kodio. So she can show the domains both as she's creating the Ashakodio with her patient, and she uses it as a way of making sure that she's going through all the domains that, kind of the cab decided should be in there. And yeah, the last thing is, so the one that you see on the right is a version of like a prototype safety plan that like they created in the training. It's not someone's actual safety plan, but in any case, that's what it could look like, right? So what you see is like it's still relying on some written words, and so that's what prompted us to think more about it. But in any case, that's kind of like what it could look like. They also thought a lot about what the domains of an Asha Kodio would be, and kind of like how we should adapt that. And so in particular, we thought a lot about, again, like, what is it? Like when people are coming to you with this problem, what are you explaining to them is happening and why they should be doing this, or why this could be helpful, or why this material thing could be something that helped them. And so that's a part of why, again, this like Asha Kodio concept is really powerful, because it's like a little bit self-explanatory, and doesn't require as much additional explanation than if you started from a place of like crisis planning, for example. They also thought a lot about what to call particular domains in order to get at like to allow people or to elicit from people in a safe and helpful way, kind of what their narrative is, or what their sort of story was related to suicide, to extract things like warning signs and coping, and kind of what to do in that situation. And so warning signs in particular was this like really like weird thing that was really hard to figure out, like, what is it that is important about this? And then like, how do we explain it in a way? And sort of capturing, again, like an idiom that was really salient to this experience of suicidality in general, something called kapna na sakne, which just means like it's like sort of being unable to tolerate or handle a situation. And so instead of framing like what are your warning signs, it's like when you are in kapna na sakne, like what is happening? And like what gets you there. And so again, it's just thinking about ways of like eliciting some of these aspects of a crisis plan or a safety plan in a way that sort of culturally makes sense. And I'll give you a few other examples from the other projects. And then, things about like internal coping and like distraction, like those often ended up being like the same things. And so there was like a lot of conversation about like, should we really just like be condensing some of these things, right, into like one domain, because people were like repeating themselves a lot, like initially. And so additionally, this idea of like people and places for distraction, or this idea of distraction, like there's not a lot of places that people can go like physically. And so again, like really reorienting some of these domains, to avoid overlapping with coping, but then also be sort of like contextually salient for a woman, for example, who might sort of like have this sort of limited kind of mobility or access. And then finally, this idea of environmental safety, or like means distancing. We learned a lot about kind of what this looked like when you did it with an individual versus when you did it with a family. And so families like problematized a lot this last domain in a way that was really important for us to learn about how to frame it in a way where the family believed it was like safe and helpful. And so, for example, there were a lot of thoughts about like, why are you giving them ideas about methods, or why are you even having them think about why they might hurt themselves or how they might hurt themselves. Like that was really seen initially. There were a lot of concerns from families that we were working with, even though those concerns weren't initially present with the cab. And so again, it's just an example of something that we tried out, and then we kind of like had to think a lot more about in the presentation of it and in the explanation of it when someone's developing their plan. We also thought a lot about how do we measure kind of like how good these things are in a context where like they look quite different and they're being used in a different way, and who the implementer is sort of like it could be a nurse, it could in other contexts be a peer, it could be, something else. And so we thought a lot about, because we don't know why this might work or how it might work in these contexts, right? Because like no one's ever done this. And so we thought a lot about like, well, how can we measure all these possible domains in order for us to eventually see if something matters more than another thing? And so we thought about measuring, of course, the content, right, which is typical. Like I think a lot of times when they do safety plant quality assessments, they're certainly like thinking about like how many things are there and how personalized are they, which are these first two columns about like quantitative and qualitative personalization. But then we also wanted to think a lot more about like how collaborative was the like actual physical creation of the document. So, like, what I mean is, like, who is like putting a sticker on it? Like, who is actually writing something out? Is it the person themselves, right? Or is it the implementer? And, like, does that matter in this context, right? And so we thought a lot about that. And sometimes it was the person, sometimes it was their family member, sometimes it was the nurse, but we wanted a way to be able to figure that out. And so we tried to think about ways to measure that. And then we also tried to think about, like, how did the idea of what ended up being on the plan come to be, and how collaborative was that? Was it certain just generated from the patient sort of, and that's it, and then it was just written down on the plan? Or was it generated by the patient and then sort of talked about, through kind of like how realistic is that? What might be the challenges of doing that? Or like, here are some other ideas, or something, right? Like, what was that actual like idea generation process like? So we try to measure all of those things. In addition, when we started doing this, we implemented these three other things that you see on the right. And so we implemented supportive supervision. So anytime someone was doing safety planning, we had regular, I mean, this is typical in the psychology space, but not typical at all in the clinical, like biomedical space in Nepal and Pakistan, and probably honestly, like in the United States. But like, so we're giving nurses supportive supervision so that they can see what they're doing, they can see kind of where quality can be better, and then they can get feedback from someone. And then there's also CAB consultations. When we come up with things that are really problematic or that are challenging or new things, we go back to the CAB and we say, hey, what can we do about this and how can we make it better? And then we use measurement-based competence. And so we use something that's done a lot in international, like sort of task-shifted psychosocial interventions, which is an observed behavioral rehearsal checklist with something called the ENACT. That's developed by Brandon Court. And so anytime someone's doing these safety plans, they get an ENACT score, and we use that in their supervision. So there were lots of things that we identified as being barriers and facilitators, some that were contextual, right? So we were doing this in a hospital. People are coming from super far away. And what ended up happening was by the time they left the hospital and went back to their community, their safety plan made no more sense. So what they originally developed in the hospital in their crisis was like not relevant for them once they got back home. And that's why this contact follow-up was actually so important, and why, continued care would be so important. But thinking about this as like a brief intervention in isolation was just like, it didn't make any sense. Like it had to be followed up upon, because people can't imagine and they can't practice or they can't do things, right, when they're in this clinical setting that is like so severed from their actual reality. Additionally, doing these things in the hospital just had a ton of inherent sort of power dynamics and one-way communication, and just ways that things have been done for generations, and expectations from patients about what providers would be doing for them in a way that required a lot of like sort of thoughtful supervision and oversight to get the providers to do it in a way that made sense. But in the same time, like we could actually get nurses really motivated because we could create this additional credential of like being a suicide prevention specialist for them to do it. And that was really great. And then, just to highlight a couple more things, and I'll kind of move on. The clinicians, this sort of idea of negotiating, they're like quite underprepared, because they were more prepared to tell families what to do and to recommend to families what to do, and less sort of in this collaborative negotiation process. And then, I guess the last thing is, we didn't do enough to privilege illiteracy. So we had these stickers, we had these ideas of making things visual and not require as much sort of literacy, but it still did. And people that were not literate still could not really use their safety plans. But in those contexts, often that safety plan became this really valuable and deeply meaningful object for a family member to keep that person safe. And so it's not that they weren't helpful, but they were just helpful in a very different way for a different person. But in this sort of family dynamic, they did matter. So, we thought, so, it was very clear to us that we had to decentralize. We had to get out of the hospital because we needed to be in places where people could sort of use these plans in a way that made sense. And then we also wanted to integrate it into the primary care system. And so part of why we wanted to integrate it into the primary care system is because MH-GAP is in the primary care system. And MH-GAP is training people on all of these things in the middle. One of those is self-harm and suicide. And no one in over 90 countries where this has been implemented has actually assessed how well is that module implemented. And if it's not being implemented well, how can we improve it, right? And so we thought, well, we've been thinking a lot about how to get providers to do suicide prevention and thinking a lot about this ASHA Code. Maybe that would help MH-GAP do better, right, in this suicide prevention space. So MH-GAP tells providers, it determines a risk level of suicide. And then it gives guidance on what psychosocial education to do, what safety procedures to take, and what follow-up to do. And it tells people that they should follow up with someone at risk for suicide for up to a year, right? No follow-up is happening at all. And so we wanted to develop a way to do this suicide prevention stuff in a way that filled gaps in MH-GAP implementation, but also sort of like used a lot of the stuff that we were really thinking about. And so we did a lot of rapid ethnographic clinical assessments in these primary care facilities. This is one primary care facility in Dholaka, Nepal that we work. And we asked a bunch of PCPs, how are you implementing MH-GAP? Tell me what's going on. We observed it sort of being implemented, or rather not being implemented. And it was essentially not being implemented at all, right? Like people get trained in it and then they didn't do anything. So then we got all those PCPs together and we were like, cool, let's figure out how we can enhance what you're doing. And we didn't start with telling them to do ASHA Code. We kind of like wanted to see would they get to the same place. They ended up getting to the same place. And so these primary care providers ended up co-designing their own package to enhance the suicide prevention delivery of MH-GAP. And we took the ASHA Code and tried to make it better to not be as reliant on literacy. And so again, really anchored in lived experience. We did a ton more co-design. We implemented a bunch of implementation strategies to get primary care providers to do this better. That was incorporating more supportive supervision for them. Again, they were trained, but then never supervised to do suicide prevention work. We task shifted a ton of the work away from them. So they do their initial sort of ASHA Code with a patient, but then we task shift out to their community health worker to make revisions on those safety plans, to practice those safety plans, to sort of troubleshoot kind of what's going on in those safety plans, and then to also help with some of the follow-up so that the primary care providers aren't doing all of the follow-up. They're sort of being followed up in their community. And then what we also did was really focus on the first part of this safety plan is called Merokata, and that just means like my story, is we focused more on storytelling. So we anchored the safety plan, again, in America, like it is really anchored around storytelling in the beginning, but we really thought a lot more about that. Oh, I'm like at time, huh? Is that where you're, okay, so I'm gonna try and like speed through it. So this is what it looks like now. We're piloting it. And so this is being done in a hybrid trial right now with sort of this package of implementation strategies. We also thought about doing this with youth. So we got another youth advisory board who are these like super amazing folks. I don't do youth work. This is the first youth project I've ever done. And so I worked with a ton of, now we have our child psychiatrists and child psychologists and like just these amazing, this organization called SoChai, which is a youth peer-driven innovation organization in Nepal that thinks a lot about expanding public health to youth. And so they decided to make safety plans into these bracelets. And so this is our prototype bracelet that was co-designed by our youth advisory board. I have so much to say about just engaging a youth advisory board in suicide prevention stuff in general. But a part of it was to think about what is a safety plan? What is the process for safety planning with youth? This is what they came up with some sort of indigenous jewelry, but then also making these like little bespoke beads. And so they actually create their own beads on their safety plan for the different domains that they come up with together. And then the other part of what they're co-designing is how do you engage families in this process in a way that is safe, that they want, and that like makes sense in that context, and that the families are on board with. And so a part of what we're doing is making recommendations to Nepal on kind of what does family engaged safety planning look like in a way that is like youth-centered and youth-focused. So this is what it looks like with our youth. Again, we're still in the co-design phase and we'll launch probably the actual trial in February. Whoa, that's like, yeah, probably February, March. So fingers crossed. The last one I want to show you is what did this look like in Pakistan. So this is the Puramid Zindagi program. Again, we work with indigenous artists in order to think about safety, like sort of suicide prevention among women. And so what these women wanted was suicide prevention. So we had a group of a community advisory board of mothers with lived experience of suicide, and they decided that they wanted to train peer mothers to deliver this package of interventions with other moms that were at risk. This is our grounded theory paper of where we started. This helped us sort of frame kind of why is suicide happening? How do people think about it? What should we measure? And so it gave us a lot of information. The way that safety planning is done in Pakistan looks wildly different. So they call it the Purumid story. So they call it their hopeful life story, or their full of hope story. And instead of sort of going through domain by domain, they actually like work with their peer to narrate their own story using this sort of like visual comic, like visual novel of Shugufta and Shugufta's journey through her suicidality. And so Shugufta, they sort of tell the story of Shugufta, and as Shugufta's story gets told over multiple sessions, they develop their own story about kind of what happens to them, what, you know, again, sort of some of these common domains of safety planning, but then also like what in their story they want to happen. And so this idea of storytelling and framing, it was really deeply important. So those were the implementation strategies we used there in concert with the lady health workers in the primary care system who work to support and supervise the peers that are delivering the safety planning. And then I wanted to show you a quick example of what our competency-based sort of training looks like. So this is kind of when we use that in ACT, and when I told you, like, we try and measure things to make sure that the peers are doing sort of the work with the quality that we want and we anticipate, and then we just use their scores in the supportive supervision to guide kind of what they need moving forward. Given the time, I'm gonna stop there and just say thank you and would be like happy to talk through any questions.
So great. I just love how you, everywhere, it's just manifesting in all these different ways. It's so exciting. I just want to throw it open. People feel free to just jump off of mute and speak, or we've got the chat available to type in any thoughts, questions, observations.
Ashley, this was such an incredible presentation, and I really appreciate the work that you're doing. And something that I'm reminded of as you were talking is how these interventions that we've developed here in the US can be brought to other places, but also like there's so much potential in bringing back what has been co-designed in these other countries and in these other cultures to kind of our own, you know, practices here. Like I'm thinking about those bracelets and whatnot, and I'm thinking about, you know, Taylor Swift and all those friendship bracelets everyone was making the last couple of years, right? And how that could be something maybe that our youth here could also really like benefit from as like a practice and whatnot. And it's just so incredible to see the potential of like what's been adapted can now also kind of be brought back, and that there's like some cultural sharing that could be happening there. And then the last bit, you talked a bit about what you were doing in Pakistan, and it just, I've been thinking about like how do we re-script people's narratives around suicide, like similar to how we do nightmare re-scripting. And it's so incredible to see you actually doing that work and that it's things that folks kind of feel like is helpful for them. Um and I'd co-designed with you. And so it's very exciting to kind of see what you're doing and how that kind of interfaces with some of the work that I would like to be doing. So thank you so much.
Thank you.
I'm noting Michelle was highlighting that she's reminded about the influence of peer relationships and how much people appreciate the visual portion of it. And I think that the visual is such a innovation around this, and the physical, like the bracelets are really a physical manifestation. Have you, does that, it seems like it's not just a question of literacy, it's that perhaps you're finding that that words just aren't necessarily the most relevant thing here.
Yeah.
It's not just whether or not people can read.
Right. Right. It's also just that, yeah, it's not a useful practice for them to sit down and write something together. Like that's not the it's not as salient, right? And so I think this idea of sitting down and sharing a story or sitting down and creating that piece of jewelry is something that makes much more sense. Yeah.
Yeah, I'm just reminded that, I mean, I don't want to sound cynical when I say this, but it's okay. We're living kind of in cynical times, but yeah, there's a part of me that wonders that if the purpose is of a lot of creating these safety plans are around the, legal liability that a lot of providers feel when they're working with someone who has been reporting suicidal ideation, and it speaks to I think it was your study in Pakistan or no, it was the earlier when you were mentioning the providers got trained in this, but they were, I don't want to say hoping, but they were expecting their patients to initiate the conversation around suicide, not actually like ask them directly, and for fear of getting, angst from the family. So that, it just, I think the cultural pieces of living in the US too, maybe inform a lot of what the gaps are in care. So I don't want to sound too cynical, so I'm going to stop.
No, I mean, I think, but all of that is like so important, especially for implementation. And like something that we've been thinking about, is these safety plans can and should be just as useful for the care provider as they are for the patient. And so we were, in some of these things, it's kind of clear that like the provider can have a copy of it or something. But like in the case of peer delivery, like they're not their clinician. They're not the ones sort of responsible for caring for them. And so like, is that like, what is that? What does that look like when you're sort of decentralizing it out of the clinical relationship and care provision? And so that's also something that we've been thinking about.
I'm also reminded that, like, in one of Craig Bryan's talk around crisis response planning, he talks about how even just the awareness that the plan is there can be really helpful for folks. And so even if you're wearing it on your hand too, like I imagine there's like a sense of like security that comes with knowing that you have what you need just kind of like on your person, versus like trying to figure out where you put your crisis plan in your Bible or your purse or your car or what have you. It's just so much more accessible.
I mean, I would be curious to know from others about kind of like when you think about measuring quality, like what are the kinds of things that you are thinking about?
I was thinking about how much quality is tied to your underlying conceptualization of what this plan is all about. That, there's a lot with safety planning intervention, the SPI version that Barbara Stanley and Greg, when I got trained in that, there's such a sense of the adherence being like very, very step by step of like being sure that things got identified, being sure that you troubleshooted each and every step along the way. and thinking about how that shapes the provider into a very directive process, because that's what you're being sort of shaped to. And a lot of what you were talking about in your fidelity is more like how much did they generate it. And if you do too much adherence about what the clinic, if it's too much on the clinician, then the clinician sort of takes that feedback and like gets more and more like bossy and controlling about the whole thing, because like that's what they're getting shaped to. And one of the things we're trying to develop is building clinical narratives and centering patient's story in the way primary care providers talk to patients, and the way the collaborative care providers talk to patients about their suicidality, to just let them speak, let them tell their story. And I think thinking about adherence for that, where you're like directing the clinician to do something, but part of what you're directing them to do is not to do something, almost, if you know what I mean. And I think that's a tricky thing, because I do think the controllingness of safety planning has come across to a number of my patients who really feel like it's been directed by whoever did it with them, not really themselves and what would work for them.
Yeah. I see Mary Rose's comment here. The biggest stigma, there's two. And I think one of them is, I think it's fair. And a lot of what we do is try not to frame anything as like myths versus fact, because it's really unhelpful in this context, because this idea that talking about suicide is okay and not harmful is not people's lived experience, right? People's lived experience is that when they share that, they are harmed. And so a lot of what we do is like attending to that, and finding ways to talk about these things that where there's sort of more trust building and allowance. And so we work a lot on that, because just some of what we frame as myths here in the United States don't hold up. The other the other problem I kind of mentioned, well, there's so many. So this idea of like talking of like planning around means distancing. Some of like means distancing is not as obvious in a lot of these contexts, because like what's being used is like just always there. Like you can't do means distancing. And so having sort of like a focused part of the safety plan on that is like, it's just not always applicable and relevant, because it's pesticides, which are always around, or it's a knife, or it's like a dupatta, like someone's scarf, for example. And so it's like, we had to think a lot more about how to have those conversations. And then the last, and then this idea that planning around that would be helpful rather than harmful. And so families were very, very concerned about like having that conversation about like, well, what are you going to do with the pesticide, or what are you going to do with your family planning pills? Because a lot of women use their birth control. And so like those kinds of things, like we had to think a lot about it. And then finally, just this stigma of like, it's not like who brings it up, has been like probably the biggest challenge. And one really interesting thing, because we just started recruiting the patients in the primary care trial, we have only recruited female patients. Only female patients. And most of those patients are over 60. And so what's happening is like we're seeing very clear like stigmas or biases play out from the providers themselves, because they are the ones doing the screening and then referring their suicidal patients right to the community health workers, and thus like then getting randomized into our study. And so well, actually randomization is at the provider level, but anyway, there's like some really clear gender bias happening that like we didn't anticipate. Again, it like hasn't come up. I mean, it kind of has come up, but like we do not have a single male participant yet.
Interesting. Yeah, it's interesting thinking about how they're, yeah, and fortunately you have your advisory board to help you
Yeah,
think
yeah,
about that.
exactly.
This is a time when you were so happy you have them.
Right. But yeah, they like just gave me the data last week and I was like, wait.
So thank you so much. I want to really say how much we appreciate this. I really appreciate the folks giving us an evaluation as well, just to kind of help us shape these presentations to be the kind of thing that is helpful and useful to you. And I appreciate everybody coming, and thank you, Ashley, so much for taking the time to present this to us. And I hope everybody has a great longer weekend, or at least in the US we will.